What are hypomethylating agents?
These are not a new class of drugs. Essentially, these are what we call, they belong to nucleotide analogs family. At the beginning, when they start the drug development, we usually would try to go to the maximal tolerated dose. So in cancer treatment, we try to go up with the dose till we get to a point where the drug is toxic. We cannot proceed any further. By doing so, we discovered these drugs are being toxic, but then why do we need them for? Because already we have toxic drugs such as Azacitidine that can really kill leukemic cells. But then investigators went back and they discovered the drugs can be effective at a lower dose. And that is what they called hypomethylating effect. So what does stand for and how it does work? And here I will go into how these drugs work compared to other chemotherapy. There's something called epigenetics. Essentially, when we are born, our genome, the genes we have are the same whether we're an eye cell or a kidney cell or a skin cell, liver cell. But yet, they function differently. What that means certain genes that we need their function in the liver, that we do not need them in a brain, they silence in the brain and vice versa. There's a process called silencing that happens early on at the conception, from the first day of life. And then there's silencing happening, which is a normal process. But then our body has certain genes that are supposed to suppress cancer from happening. They watch over abnormalities of the cells. Imagine these abnormal genes are being silenced. If they're silenced, they cannot do the role. And therefore, they silence because, among others, they have a methyl group that get attached to this part of the gene. When we went back to these quote-unquote hypomethylating agents, we discovered that at the lower dose, they can remove the methyl group and let the gene express itself. And as such, it can suppress the development of cancer. And that is what hypomethylating agents. Therefore, they are not strong chemotherapy, but they have a specific effect to express certain genes, supposed to be expressed, but for a reason or another, were silenced and cancer took place. That is, in a simple mechanistic way, how these drugs work.
How do hypomethylating agents work to treat AML?
When cells are being renewed on a daily basis, in cancer, the hallmark of cancer, cells do not die. In our normal body, so you have your skin that in the summer get tan and then die and you have a new skin formed. So there's a cycle of life. Our cells are scheduled, are programmed in a way. They're born, they grow, and they die. So cancer is, there's no death of cells. There's something called death, we call programmed death, apoptosis, as a scientific term. So there's inhibition of this process. As such, cells are living normally. Essentially, there are certain genes that are being silenced, not functioning, and therefore they have zero function against AML. By removing the methyl group, CH3, and then by expressing these genes, the genes supposed to suppress cancer are being active, and that is hypothetically supposed to suppress development of cancer. This is how it works. So by removing the methyl group and expressing these genes, we expect these genes to suppress the cancer, and the cancer cells resume their normal cycle of life and go to die, and therefore killing leukemic cells.
What are the hypomethylating agents currently being used to treat AML?
What are the currently hypomethylating agents being used and how they are different? There's two drugs available. The first one was 5-azacitidine, and the second one is a decitabine. The 5-azacitidine is given sub-Q and intravenously over 7 days of treatment, and decitabine is given IV daily for 5 days. The decitabine was explored as sub-Q formulation as well, and oral formulation. Sub-Q formulation did not succeed. The 5-azacitidine will transform into decitabine inside the cells, the substrate to kill the cells. And both were tried in a randomized trial, and both were effective. In my mind, they are both equivalent. You can use either one.
How is azacitidine administered?
It can be administered either sub-Q formulation or IV formulation. I offer either one to my patient, depends on the patient preference. I can tell you when you give sub-Q formulation, some people can have pain at the injection site. If they have low platelets, they can have some small hematomas, and some patients may not like it, and they prefer IV formulation. The IV formulation is 1 hour infusion. If I want to go to my work, I'm in a rush, I want to take the sub-Q formulation. So I have a group of patients. Those who will tell me, I don't care about the pain, I want to in and out, I want to resume my normal functional life activities. And others, I hate the pain, I'm scared of the pain, give me IV formulation. So both are equivalent and both can be used.
How is decitabine administered?
It's administered intravenously over 5 days. We have oral formulation, but there are different drugs. In a way, I say the oral azacitidine is different than the IV we give, different indication, different function compared to the IV formulation. And then decitabine is given IV. We tried sub-Q, but that did not succeed. So we have IV formulation, giving daily for 5 days. This is the standard of care. We explored the oral formulation, where we assess the pharmacokinetics of decitabine given orally versus IV, and we found the best dose is equivalent to IV formulation when given orally. And therefore, today, we have either formulation. Now, that being said, the oral decitabine is only approved for MDS, not yet for AML. In AML, it's given off-label, but everybody is using it. Who are the most appropriate patients to receive hypomethylating agents? In clinic, we investigate this agent in different settings. But where we've seen activity is in a disease called myelodysplastic syndrome, where we see this kind of silencing happening extensively, and in older patients with AML. So in myelodysplastic syndrome, there's 2 drugs available and approved, decitabine and 5-azacitidine. Both are active and effective in MDS, and therefore the drug were first approved in this setting. Then these drugs were investigated in acute myeloid leukemia. They found to be effective, although the authorities did not approve this drug for AML in older population, till recently when we had combination, where we added something to HMA therapy, and we can talk more about them later today.
What are the common side effects of hypomethylating agents?
What are the common side effects of hypomethylating agents? There's minimal side effect. Essentially, when we went to very low dose of the treatment compared to full dose as part of the family of cytarabine, we did not see the myelosuppression we do see with high dose. So essentially, it's very well tolerated. Patient may experience some fatigue around day 7, 8, and 9, but very mild fatigue. And of course, we can have a drop of the count, but drop of the count is inherent to the disease by itself more than the drugs. So I think these drugs are really quite safe to be given compared to intensive chemotherapy, and this is why they're really commonly used in a community setting without major problems.
How are these side effects typically managed?
How are the side effects typically managed of HMA? As I said, the side effect profile is very acceptable. I usually, when I have patients in my clinic, I explain to them what I'm giving to them, how the drugs works, why I do not expect side effect to be something of a major concern. I explain to them the fatigue may happen a few days, around day 7 to day 10. So if you want to go for a big trip, try to avoid it, as communication always works with the patient. And then low count. In the low count, I advise them to get blood tests done weekly to see if the count is dropping. Patient may need blood transfusion, platelet transfusion to be given. And of course, when the count is low and the patient with AML have a very weak immune system, they can have fever and infection. I advise them to go to the hospital to be on antibiotic therapy. And on top of that, when the count is low, when I do blood tests weekly, I put them on prophylactic antibiotic, a prophylactic antifungal therapy and antiviral therapy, so to avoid such complications. Are hypomethylating agents used alone or in combination? In MDS today, they are approved alone. There are several combinations done. They were not successful, such as histone deacetylase inhibitor or other compounds. Although today, there's new drugs being explored. Among them, BCL2 inhibitors, PD-1, PD-L1 inhibitors, immune therapy added to hypomethylating agents in MDS. There are ongoing randomized trials. We're eagerly awaiting the results to see if we can further improve on HMA alone. because HMA are effective, but they are not like a breakthrough. We need really to build on them to make them better. That is in MDS. In AML, we succeeded to have a combination. In fact, in acute myeloid leukemia, especially in older patient population, we added a drug called venetoclax or a BCL2 inhibitor. Again, the idea is these cancer cells, we need to put them to death because of this life cycle is being abnormal or perturbated. So this BCL2 inhibitor can put the cancer cells to die. Therefore, they're synergistic with the HMA. And in that sense, there was a trial where we combined decitabine or azacitidine with the BCL2 inhibitor, venetoclax, and we've seen the responses in AML going from 25% approximately to 65%, and the survival went from 10 months to 16 months. And that was confirmed in a randomized trial where patients were randomized to either HMA plus placebo or HMA plus BCL2 inhibitors, and the new arm for BCL2 inhibitor, venetoclax plus HMA, was 5-azacitidine, was found to be superior, higher response rate, better overall survival, and more eradication of the disease, and that has become our standard of care. So we moved from hypomethylating agents alone to a combination, and that was successful, and therefore now we have a new backbone to build on it. Building on it means maybe adding other target therapy, be it IDH inhibitor, FLT3 inhibitors, or others. So we're walking away from HMA to HMA combination to further improve the outcome.
Can hypomethylating agents cure AML?
I think cure is a big word. I'll tell my patients, today I have somebody with acute myeloid leukemia. I want to do my best to get them in a better shape. Means I want to eradicate the disease. I want to eradicate what we call minimal disease, that we don't see it morphologically. These are cells hidden somewhere that can drive relapse and resistance down the road. And we know when we give HMA only, in AML, survival is around 8 to 9 months, so we need to improve on that. You can tell me the majority are having a short survival, but I can tell you, if you look at the tail of the curve, certain patients can have a long life. And whether you call it cure or not, that is up to you. But I can tell you there's a subset of patients who can be cured down the road, who can have a long-term survival. I don't think HMA alone will make it. Realistically, we need a combination, and we need eventually to get patients to transplant. Because while these hypomethylating agents are being given for older patients, physicians give up. Oh, he's an old patient. Why want to go for a transplant? But patients are sick often at the beginning because of their disease. So if we can treat them, we can improve their conditions and maybe do non-intensive transplant that can consolidate the remission and lead to long-term cure. So when I see somebody in my clinic and will tell me, hey, doctor, I'm not optimistic, the numbers are scary. I tell you, yeah, the numbers are scary, but do not take the numbers to judge your future. You're a unique person. We're going to do everything to secure the best sequence that can lead to the best long-term outcome. Will I succeed in the majority? The answer is unfortunately not today. But will I succeed in a certain patient? The answer is yes. And maybe this patient A is a unique patient where I can offer a long-term cure by administering the best combination and the best sequence of treatment that can lead eventually to the best chances of long-term cure.
What research is being done to make hypomethylating agents more effective?
What are the researches being done with the hypomethylating agents to make them more effective? I'd like to highlight that we have a new formulation of hypomethylating agents because patients do not get the IV injection every day. I mean, if you can get the pill and be at home, why would I go to the hospital? So we succeeded to get decitabine IV. We have an oral formulation as effective as the IV formulation. So now we have oral decitabine that's being given. For azacitidine, we're not there yet. There's formulation approved for maintenance, where patients with chemotherapy who are not transplant candidate can get a maintenance with pills. But these oral pills, these pills of azacitidine are not the equivalent to the IV formulation, unlike decitabine, where you convert one pill to an IV infusion. It's given 14 days every month. But right now, we're exploring oral azacitidine to be equivalent to the IV formulation or subQ and to replace the way we give IV or subcutaneous azacitidine. That is being done right now, but we're still behind the decitabine. The research are being done at two levels. Number one is to have a better understanding of the biology of the disease. Again, I will say AML is not like one disease. It's a spectrum of diseases. And we have to dig into that to each patient identify his or her own biology, because this will dictate how I treat. It's not smart to give a treatment that fits all. It doesn't work this way. So the first thing is have a better understanding of the biology, identify targets that we can go after them. Then I can design a treatment a la carte. And that will bring me to the second chapter of the research is what are the best combination to offer the target specific population. That's how we make progress. In this sense, we have different approaches. I discussed HMA BCL2 inhibitors. We have FLT3 inhibitors to be added to HMA, or FLT3 inhibitors added to HMA and BCL2 inhibitors, IDH1 and 2. The group of patients where the outcome is really still poor are the group who have the complex karyotype and the p53 mutation. These are really, really bad patients. For these patients, for example, we're exploring new agents that can target specific p53 abnormalities. There's a drug called magrolimab, and others in that sense are being explored for these patients. These are happening right now. I know, for example, CML was CML transformation into AML or CML blast crisis. For example, for this patient, we can give tyrosine kinase inhibitors in combination with HMA that we hope to further improve the outcome. These are happening right now, and I think the future is bright. We want to make progress, and patient will have a better outcome.